Good morning. We're on week 3 of the osteotomy course. Thanks for joining us. Again, myself and Michael Sirkin are the chairs. I'm Brett Christ. And so we're kind of going over this at the beginning each time just so everybody can get on the same page, since some of you may be joining kind of part of the way in and have to look at the previous week. So this is proximal femur module, and this is a patient of mine who fell 2 years prior and was continuing to complain of right hip pain and was still limping. And so this deformity can be challenging both to evaluate and may not be something that you guys encounter every day in your practice. So the goal of today is to help you not stress out and not worry, and we'll help you understand how to evaluate it, the indications for osteotomies of the proximal femur, as well as you make you more comfortable with at least the understanding the techniques, and then after the live event, hopefully make you more comfortable. That's what she ended up getting, is an intertrochanteric osteotomy. And so the goals or objectives for the entire course are to identify how to correctly evaluate lower extremity deformity and nonunion, list the indications for deformity correction, perform these techniques, and that would be more at the live event to restore extra-articular alignment, utilize techniques for intra-articular osteotomies, and then recognize strategies for leg lengthening and bone transport. So weeks 1 and 2, we talked about evaluation of lower extremity deformity, both on plane films for coronal plane and sagittal plane evaluation, primarily coronal, and then also on CT scans for rotational profiles. And then last week, Keith Mayo and Raul Vadia went through just a generic planning for proximal femoral osteotomies. So we've gotten through part of learning outcome number 1, and we still have the rest of them to go. And so this is a 10 Saturday event course. We've gotten through, this is now going to be the 3rd one. And it's a live event online. This is a recorded event that will be available with a link for the registered participants through Zoom tomorrow. And then an edited recording will be available at the AO Trauma North America YouTube channel, likely on Monday. We also have 9 Thursdays at 8 p.m. Eastern, where we have Ask the Expert session, where the participants can ask the people that have been involved with the prior week's module. Sometimes we have homework for you. You can present your cases on some of those Thursdays, and then ask questions for sure. And then you can also catch up on from the live event, because we do a recap as well. And that's recorded as well and available on YouTube. And then hopefully, as the pandemic issue continues to move on, hopefully we'll be able to do a live event in the fall in Las Vegas to do cadaveric practical exercises and some synthetic bone models as well. And so again, this is new territory for us to have a completely, or the majority of online learning. This is called blended learning, where we have online as well as in person, but there is an opportunity for you to ask questions, and please do that through the Q&A section, because we save those questions. So please don't use the chat function. Only use that if you don't have the Q&A function available. We'll ask for cases at certain weeks, and then you'll get multiple email notifications just to make sure that you have the correct links and the ability to register for each event. So the live event is going to be in Las Vegas. It's going to be a Friday afternoon and a Saturday morning. We'll have 1 full day of practical exercises, including cadaveric osteotomies, synthetic bone planning, and osteotomies. And it'll be a 2-to-1 participant to faculty ratio. And there'll be a Saturday evening event with the faculty to help foster mentorship, as well as get people connected to each other. So we're hoping that's going to happen. We don't know exactly when that's going to be. Eventually it will take place. So just as I'm sure everybody's familiar with Zoom now, or something similar to that, but for this event, your microphones and videos are muted and turned off. Again, send your questions through the Q&A, and we'll have different Q&A sections. Try to avoid using chat unless that's the only available way to ask questions. The moderator will review questions as they appear and present them to the faculty. Use Q&A for questions related to this particular discussion topic, because we're going through modules. And so if you ask something from the week before or something down the road, we'll try to ask you to wait. So these are the faculty for the entire course, and those highlighted are those involved today. So again, I'm the moderator of this module. The presenters are Roger Wilbur, Keith Mayo, Mark Riley, and Mike Miranda. These are our disclosures, none of which are particularly important for this general topic. To obtain CME, this is how you do it. It's worth 1.5 credits, and you'll get a link to do an evaluation and then get your certificate after that. So the learning objectives for this session is that you'll be able to list the indications for proximal femoral deformity correction and non-union management, and then utilize proximal femoral deformity correction techniques to restore extra-articular alignment and address non-unions. This is the agenda. So Roger Wilbur is going to kick us off with femoral neck nonunions. Keith Mayo is going to talk about proximal femoral osteotomies and non-traumatic deformity. We'll have a question and answer period, and then Mark Riley will be doing Peritrochanteric malunion. Rotational deformities will be addressed by Mike Miranda as well for the proximal femur, and then we'll have another Q&A section.
All right, so it's my my goal this morning is to talk a little bit about femoral neck nonunions, and the question is when and how. And theoretically, we're supposed to do this in 10 minutes, so there's a really long legacy of hip surgery, and I think that unless you're the best hip surgeon in the world, best trauma surgeon in the world, you're going to have to deal with femoral neck nonunions. The reported literature is upwards of 10 to 20% with open reduction interfixation and femoral neck fractures. So if you're a trauma surgeon, you're going to have to deal with this. I learned most of what I know about doing intertrochanteric osteotomies from Jeff Mast and Keith Mayo, but there's a long and storied history for intertrochanteric osteotomies. They learned most of what they knew from guys like Rene Marti and Maurice Mueller, who learned a lot of what they know from Renato Bombelli and Paul Mackay and Friedrich Pauwels. So there's a very long history to this operation. And honestly, not a lot has changed with respect to the techniques and how it's performed over time. And the techniques that I will show you today really have been passed down over a long period of time. So my objectives for you at the end of the session is to understand how much correction is appropriate, know who is a candidate and when to perform the surgery, and then to be able to convert your plan into a surgical tactic, because Keith and Raul did a really nice job about creating a plan last week, but now it's up to us to be able to translate that. You know, there's a quote in the wall at the Congress Center at Davos says, "I was never such an expert when I started on a topic." If you want to feel humbled, go back to the old textbooks, and I really suggest that you do this with Paul Mackay and Friedrich Pauwels, and just look at how much time they spent understanding the mechanics of the proximal femur. You know, the basic point is that there is both a compression and a tension side to the proximal femur based on the fact that we have an angle to the neck. And the idea behind all this is to remove the tension side of this and convert it all into compression. So historically, Keith mentioned that a lot of this was done with just very simple fixation techniques using tension band wires and that sort of thing. But it did leave a lot of people with rather straight or pencil type of legs, because what they're trying to do is completely eliminate the tension side and go all into compression. So large wedges were actually removed, and typically we were talking about 30 to 35 degree wedges that were taken out, and that would convert the Pauwels angle into one that was 20 degrees to 30 degrees and was all in compression. A real valuable paper that helped us out a few years ago was this one that came out by Yuan and Beret and Nork, because a lot of us, what we had been doing was trying to convert things back to more of a normal shaped proximal femur, so that we didn't have quite so much deformity. And these guys presented in the Journal of Orthopedic Trauma and looked at 32 patients, said, you know what, if you don't take a huge wedge out, what's the difference? So the smaller wedges look like they healed just as well as the large wedges, the 30 degree wedges. And it wasn't a problem with the healing of either the osteotomy or the healing of the non-union. The one thing that was interesting in their paper is they also noticed that the larger degree wedges seem to have a little bit higher incidence of avascular necrosis associated with that. So That was really encouraging for me because what I had been doing was trying to restore normal anatomy, and it had been successful. And I think this shows that that's the case. The case of when do you do this is when can mean sort of when in the timeline of a patient's healing. Let's say you have a femoral neck and you're following it along and you're waiting for it to heal and you're not certain if it's healed. I would say most of the time in my career, I've been able to tell whether something is going to heal or not by about 3 months. So I'm starting to think at 3 months, if it doesn't look like it's healed, I'm feeling quite suspicious. If I want to give them a little bit more time, I will. But one thing that makes your osteotomy much more difficult is hardware failure. So I don't suggest that you wait for a very long period of time for the screws to start breaking. So then you have to extract all the screws as part of your operation. But try to choose that early. And then the other thing is when with respect to the types of patients, what patients are candidates for this. And I would like to give you just a little bit of a history or talk about a patient I saw over 22 years ago. And this is a lady that had a femoral neck fracture, but I didn't recognize it at the time. So she had a femoral shaft fracture, plateau, a pilon. She was really quite hurt and morbidly obese. We put an intramedullary nail in her femur, just treated as usual. And this is one of those cases where I went back to find the x-rays and everything had been destroyed and not digitized, which is a little bit unfortunate. But one of those cases that shows up in your office a month after you operate on them, and I put the x-rays up, and I learned a real good lesson that day, and never put the x-rays up for the first time when you're standing in front of a patient, because the femoral neck was 100% displaced and completely off, and the head was off. So I ended up going back, doing an open reduction on the femoral neck, pulling the rod out, putting a plate on the femur. She went on to a nonunion. She was in her 40s or 50s at the time. And this is, like I said, 22, 23 years ago now. And I ended up doing a Powell's osteotomy on that, pulled the plate off the femur and did a Powell's osteotomy on her. And this is the most recent x-ray that I've had, and that's not because I lost track of the patient. This was 10 years ago. Completely healed the femoral head and neck, but I've been following her ever since and have done, total knees on her and everything since then. But this hip has never been a problem for her. So I would suggest to you that you don't lose faith. You don't immediately go to total hip replacements on patients. We were very fortunate to know Rene Marti, and we're also very fortunate to have this literature that he published before he passed away. Very, 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 very nice gentleman. And these were his recommendations basically at the end of the paper. Said, do healthy patients up to 65 years of age with non-unions of femoral neck. They're candidates. Union rates can be pretty good. They reported 80 to 90%. And I think with new techniques, I think it's even better than that if you look at Sean Nork's results. And then they're getting good to excellent results on about 62%. So not everybody that heals is having a good to excellent result, but overall it's pretty good. They did warn us about little bone stock inside the femoral head. Now that's a relative term. Every patient that has a little bit of windshield wipering in the femoral head from some screws or something like that is not necessarily not a candidate. Those people still can have osteotomies and you can get a very good result. But large cavitary defects, that's a problem. And if you have radiographic signs of avascular necrosis in patients over 30, it's considered a contraindication for an osteotomy. But I'll tell you honestly, I don't look for AVN. I don't get MRIs. I don't get specialized studies. I'm not looking for it. If I have a head that hasn't collapsed, I'm considering most of my young patients a candidate for doing osteotomies. So in the 65 to 80-year-old group, total hip replacement is probably the best overall option. Let me give you some exceptions. There are some exceptions to that rule. And this is a patient I took care of a number of years ago that came to see me because she was really unhappy with the leg length deformity discrepancy and the deformity of her proximal femur. And she was 72 years old. And I'll tell you, well, the most important thing in her life was actually yoga. So she convinced me that I would do an osteotomy on her based on her activities. She had a shortened leg. You could see that the trochanter was sitting kind of high, so the abductor didn't function very well. So she was either going to have a Duchenne or a Trendelenburg type of gait. You can see that the center of the femoral head and the offset to the anatomic axis of the femur were all real short, which is also going to aggravate the limp. So these are the things that I wanted to correct. The overall antitorsion of the femoral neck actually looked pretty reasonable. So I went ahead and did an osteotomy on this patient. This one's a little bit different. in that I felt I needed to transfer the trochanter as well. So what you're seeing here in the middle portion is a piece of allograft bone that I had utilized. And she went on over time to heal this and do exceedingly well. She was one of the happiest patients I ever had, and she was able to go back to her yoga, which was one of the most important things. So I wouldn't say that everybody over age 85 has to have a total hip replacement, but I would suggest that in general, it's a much, much easier thing to do, much more difficult to do this kind of an osteotomy in that patient population. So the ideal implant for sure is the 120-degree fixed angle blade plate. You can use other devices, and I'm going to take you through a little bit of an exercise right now where we use the 95-degree. It is possible if you have large cavitary defects in the femoral head, you may choose a lower angle plate in order to get the blade into a lower position on the femoral head. Now, how do we do this? You saw some really good planning from Keith and Raul last week, but that's not really the how, that's the how to plan. But there's a lot to know after that, what to do. And I'm going to take you through those stages right now. So I still like to draw things out personally. It teaches me a lot about the osteology, and over the course of my career, I think it's been very valuable for me to trace bones and to look at them critically and try to understand them. So this is the abnormal and normal overlaying each other, and I can see that I have a pretty, if I just want to swing that femur of the abnormal one back to where the normal one is, that's going to be the level of my correction right there. So we're talking about 25 degrees. And if I overlap these proximal or the distal parts and look at the proximal, I see what the deformity looks like, and it gives me a little bit of an idea as to where I may want to put my wedge, right, when I want to start to do my correction. Because if you do your wedge someplace else other than where the deformity is, you're going to end up with a secondary compensatory deformity. So again, I know I have 25 degrees, and as Keith mentioned last week, I can play around with this wedge and I can move it to wherever I want. I can take a small wedge out, or I can take a very large wedge out, and I can pretty much put it where I want depending on what the deformity or what the osteotomy demands. In this case, there was a leg length discrepancy, so I'm going to want a little bit smaller wedge taken out, the size of the wedge, not the angular correction of it, but the size of the wedge. So I'll just put it a little bit out to the side, and that's going to allow me to get a little bit more height adjustment in this particular patient. Now, maybe you don't need that, but in this case, it does. So we'll take a smaller wedge out, and then we'll finish the cut, and that'll allow us to tilt this up, look at the normal, put it over the top of the normal. Is this going to correct the mechanical situation in this patient? Yeah, I think it does. So I'm pretty happy with the appearance of that. I think that'll give us a pretty normal looking proximal femur. And I can put my templates on there. In this case, the 95, you can use the 110 or the 120 or the 130, depending on what you want to do. And then we have my particular plan. And we translate this over to the abnormal. We figure out where that chisel path is going to be. That's all we really have to know, is the size of the wedge and where the chisel path is. But that's not all that you have to know. You have to know more than that, most definitely, because there's a bunch of stages that are going to get you to where you want to be at the end, right? What do you do in the operating room? Most people I know are putting in a reference pin to start. The reference pin is normally a 90-degree pin that you put in, and then that pin you use to guide the rest of your pins after that. So I would suggest the reference pin at first at 90 degrees to the cortex. Now, everything we do is being referenced to the lateral cortex of the femur, because that's what you have to guide yourself on. Then the second pin that we're going to need is, we're going to base it off of the reference pin, the 90-degree pin. It's the second red line. We need a pin in the bone to guide us to make the long cut of our osteotomy. So this one, you can measure off the lateral cortex of the femur. It's going to be 70 degrees. And intraoperatively, you're going to have to know how to create that 70 degree. You can either have a sterile goniometer, or you can use these wedges that they have on the kit itself, in the osteotomy kit, to do this. We know that there's going to be a 20-degree difference between our reference pin and this pin, so we just need to somehow find a reference for 20 degrees. In that set, there are a bunch of triangles that have different angular corrections on them, or angles on them. So if you look at the set, there's 3 triangles, and there's a 20 degree, a 30 degree, a 40, a 50, a 60, a 70. They even have the big ones up to 110. So you just have to pick the angle that you want. If you have a small angle, you may choose to bisect it, put it on the pin like this and use it as a bisector. So in the center of that, that wedge, you can see a hole. If you put the reference pin right in the middle, bisect it, and that's going to give you this, this 20 degrees that you can use to guide yourself for putting in that, that reference pin. Then the next pin that you're going to need is something to guide the shortcut, right? You have this smaller, shorter cut that you have to make. And that pin is going to go in based at 25 degrees, right? You need 25 degrees off of this wedge. So we'll take the 50-degree angle, we'll bisect that one. That's going to give us 25 degrees. And I can use this edge right here to guide the placement of this pin, which is going to guide my hand with my saw for that cut. So here we are. This is what we have now in our plan. We've got a 90-degree pin. We have a 70-degree pin that guides us for the bottom cut. We've got 25-degree wedge pin that's going to guide us for the top cut. And then finally, the last thing we're going to need is a pin that's going to guide us for the placement of the chisel at the top. And we measured that off the lateral cortex of the femur as well, and that's 110 degrees. So you can use a sterile goniometer, and I highly recommend that you have a stainless steel sterile goniometer intraoperatively to place that pin. Now you want to have these pins in a location that's good for you for making the cuts. You want them close enough to where your osteotomy is going to be, but far enough away that they're not in your way when you go to work on either the chisel or when you go to make these cuts. Keith mentioned that early on, you may want to put these pins in a location that you can actually rest the saw blade on the pin and cut on the pin. But in general, I find that the pins get in my way, so I tend to keep them a little bit out and just use my eye to guide the cuts. So now we have a few more things that we want to measure. We want to know where your chisel path is going to be, where you're going to start your chisel, and how you go from there. And it's sometimes worthwhile to measure the lateral cortex of the femur to know how big this is going to be. So 25 millimeters down from the top, 16 millimeter wedge is being taken out. And now you're ready for the operating room. These are some images that Brett Christ let me borrow. And you can do this operation either in a lateral position or a supine position. Honestly, I tend to prefer the supine position for myself, unless I'm doing some work on the femoral neck or I need better access, either anteriorly or posteriorly, or I'm doing a trochanteric osteotomy. But frequently I'm doing this in the supine position just because I like to sometimes reference the other femur intraoperatively. But in this particular case, he's doing a Gibson. The lower end of the Gibson really is the approach to the proximal femur, where you split through the fascia. And then you, very importantly, you go around the backside of the vastus and cleanly dissect that off. Here you can see Brett is using an elevator. And a very sharp elevator is one of the best dissecting tools for taking the fibers of the vastus lateralis off the intermuscular septum and off the lateral border of the femur. And then what you're looking at here is the proximal femur, the lateral border of the femur. And you can see that the vastus has been taken off the vastus ridge here very cleanly. And you're not dissecting over the anterior aspect or the posterior aspect of the femur. And you don't need to clean off the trochanteric region at all. So very nice dissection. When you go to put the pins in, I would suggest that the pins go in using this 2 millimeter drill bit. This 2 millimeter drill bit's, it's really quite good. And it's better than putting the pins in not under direct power, because the pins tend to bend as they go in. So I'll put it in with this and then just slide the pins in by hand. So again, start with the 90-degree reference pin, put your second pin in. This one happens to be 70 degrees to guide the lower cut. Put your next pin in to guide the upper cut of your osteotomy, and then figure out where your blade plate chisel is going to go and where the start point is for that and where your cuts are going to be. This is what you're really going to be looking at in the operating room, right? It's really just the lateral cortex of the femur. And you can, and I do sometimes, trace out where the plate is going to sit on the lateral cortex, because occasionally you may want to flex it or extend it a little bit, depending on how much deformity you have. in it. In this case, I wanted to actually flex the femur just a little bit because I felt that there was a little bit of an extension deformity to it. Again, intraoperatively, you can make marks 25 millimeters down for the start of your blade plate chisel, 16 millimeters on the lateral cortex. You can make little marks as to where you believe your osteotomy is going to be. And I like to use a small, very sharp chisel to make these marks because usually a bovie tends to wear off as you're working in there. So a small little score line using a sharp osteotome is very valuable. And this is what you're looking at. So in hard bone, I think it's very valuable to use the 4.5 drill bit and then subsequently route this out. A lot of times in a little bit softer bone, I'll just use an osteotome to open that little rectangle of bone, and I'll save that little bit of bone for subsequent bone grafting. This is very important. Make certain that you create a very good chisel path before making any cuts. If you make the cuts first and you're trying to create a chisel path, you're going to be extremely unhappy. So make the chisel path and make sure you back it out a little bit before you make any of the cuts. And there we have a little bit of flexion in it. Now, if you have a flashlight and a magnifying glass, you can see these little numbers on the side of the chisel, and it'll tell your depth, and you should know that before you do your surgery. That should be part of your plan, how deep you're going to go. And again, make certain that you back it out a little bit before you do your cuts. Then you have to make a couple of cuts. I tend to make the short cut first and then make the longer cut after that. You do have to come in and out a few times. I suggest that you use very thin blades for this. I tend to use a 0.6, not even a full millimeter, about 0.6 millimeter blade. It's flexible, but it'll give you a really nice cut, and then stop there and then make the long cut after that. Sometimes you have to actually rotate the femur a little bit in order to complete that cut. Now, a little bit on offset compression, because Keith talked about offset compression. Anytime that you have a blade plate of a higher angle, say 110, 120, 130, you have to use offset compression to do this. And the way to do this is to have something that creates a gap here in the proximal part of the femur where the plate sits off of the bone, not in the distal aspect, but in the proximal aspect. Because you have an oblique osteotomy here that you want to get compression on, and you want to create a gap here where this yellow line is. So what you're going to do is start down here by fixing the plate to the bone, first with a clamp and then with a single cortex screw that's going to give you a little bit of compression and some contact here at the osteotomy. You do have to have some initial contact. Then you're going to be left with this situation where you're going to compress and close down this gap right here. And what that does is as you tighten this screw, you're going to push this proximal segment against this obliquity. And it's that pressure that's going to cause the compression and leave you with a very, very solid and stable situation when it's done. And that technique's extremely important. It does vary a little bit from patient to patient and how soft their bone is, how hard their bone is. And you have to be careful about how big of a gap that you leave when you put that plate on the proximal segment. So in summary, these will be the take-home points. I think there's an extremely valuable surgical legacy that you should take advantage of when you plan to do these operations, when you think about them. You want to attempt to restore anatomy to normal. I want you to plan your steps very, very carefully, learn from the people that have come before you, and I think this will work out exceedingly well for you. It's an extremely gratifying surgery to do. I did include in this talk a few articles that I referenced, one from Renee Marti, one from Sean Norkenberet, Keith Mayo with some preoperative planning, and then finally there's this classic article on Mast and Gans that I think is worth having in your library.
Keith Mayo is going to do proximal femoral osteotomies in non-traumatic deformity.
Okay, so we've had a lot of treatment of preoperative planning, and what I want to do in this brief section is essentially just go over the applications of osteotomy and proximal femur for hip reconstruction, and we'll go through just cases. I'm not going to go through the planning. Each of these will have a custom solution So we'll do valgus or abduction, varus, or adduction with or without rotation. Mike Martin is going to treat that topic later. We'll do a true or absolute neck lengthening and then a limb short. Cases. This is a 14-year-old that about 18 months prior to this had dislocated his hip skiing and now has a very large necrotic segment of his epiphysis in this view. But his real problem is that he doesn't have that much pain, but he feels like his left leg is long because he has a mechanically fixed adduction contracture. It's not, so it's soft tissue, but primarily a bony problem. And so if we take our same techniques that we've used before, we can do an abduction osteotomy that will reposition his leg to give him effectively a level pelvis. And this is what it looked like when he was now, I think, 21. And I had really wanted to come back at a later date and do a lateral trochanteric transfer, but he was having none of that. You can see that he already has a lot of remodeling around the proximal femur, and he didn't want to even have the plate taken out. And here he is at age 29 with still a reasonable joint space and reasonable function. He's now 33, and the end is coming as far as his need ultimately for hip replacement. So same basic techniques, a higher CCD angle than normal, but a different overall objective. A lot of patients with hip conditions have had previous childhood surgery. This is a dysplastic hip that had been treated with a varus derotation osteotomy as a child. This is what the position views look like. It was probably a subtrochanteric level osteotomy, but we went back and through a transitional intertroch subtroch osteotomy to closing wedge and using a 95-degree plate and get back to a relatively normal position, and then the appearance at 5 years after intervention. We can do varus as well. This is a 18-year-old girl who had a previous malpositioned periacetabular osteotomy. She couldn't flex her hip. They thought her problem was a nonunion, so they went back and plated her pubis. But a real problem is the position of the hip. But more importantly, she has a valgus and inverted neck. And as part of a solution in a younger person, you have to address those issues. And so this is her aggregate total antetorsion of around over 40 degrees with a commensurate asymmetry in medial versus lateral rotation. And so our plan was essentially to use, unfortunately, I had to use a pediatric plate for this since her neck wasn't big enough for this. So I planned for approximately a 10-degree adduction or varizing osteotomy. And this is what it looked like initially. This is the longest blade that we had available, unfortunately. And we'll see where that comes in to be a problem later. So this would be the opening wedge purely. So we have a point of medial contact and a pure opening lateral wedge. And then we put an interposition graft in. And as we set that up at the end for doing a tensioning using the articulated tensioning device, what's happened is that I've actually crushed the metaphysis through this allograft wedge, and I've lost part of my correction with the tensioning. And so she probably had an eating disorder, and so her bone was not robust, shall we say. And so this is what she ended up looking like initially, and then finally at healing. So her CCD angle is down, and one of the problems with doing a varizing osteotomy is that there is an obligatory modest leg length discrepancy. I had projected for 5 millimeters. On this standing film, it appears to be a bit more than that, although actually clinically it looks level. So that's a varus, in this case, varus derotation osteotomy for the classic association between dysplasia and a valgus anteverted neck. A better example, this is a 14-year-old girl with cerebral palsy whose hip wants to dislocate. She's nearly 100 kilos, and her mom can't take care of her, so we're trying to save this hip. And this is clearly going to require both sides of the joint, and this required a fairly significant varizing, in this case, retroverting femoral osteotomy in addition to the acetabular component. And she's now almost 16 years out as well. So you can do a lot. In this case, we're willing to accept some shortening just to keep this now 28-year-old female being able to walk and do transfers. You can lengthen the femoral neck on an absolute sense. I'm not going to do relative neck lengthening, but you can do a trochanteric osteotomy. You can then follow that with a surgical dislocation of the hip. You're going to do an oblique osteotomy of varying obliquities, which will allow you to essentially laterally translate the shaft and give you a medial neck. And this is an example of what one of those look like combined with the periacetabular osteotomy. We've got about 25% shaft offset in this setting. And that's probably as much as I'd be willing to do. This was a 20-year-old when we started. And then a more extreme example is this, which is a more severe coxa breva associated with Perthes disease. And so we've been through the trochanteric osteotomy, the dislocation ultimately, and then the seating chisel insertion, and then a long oblique osteotomy. And then in the situation, we're gaining a leg length as well as an offset, which effectively gives him a much longer femoral neck. You can also do shortenings. This is a 17-year-old girl whose problem is not her Perthes hip on the right side, but pain on the left side because she has a long leg measured in multiple ways at 3 centimeters. And what happens here is there are a variety of different ways to shorten the limb. I'm going to show you only one. So she had a 3 centimeter leg length discrepancy. So this gave her an effective or accentuated her mild left hip dysplasia when she was standing on both legs. And so this is her non-standing view as far as the comparison. In a lateral view measuring to make sure we can get a standard blade in. We're going to go through this sequence again. So reference Kirshner wires. We're going to do an incomplete intertrochanteric osteotomy, a complete subtrochanteric osteotomy. We're going to do a bony resection, and then we're going to shorten this, essentially translate the diaphysis up, having measured the relative widths of the diaphysis relative to the metaphysis to make sure it's going to work. And so this is the execution with the seating chisel in place, and then shortening, and then after tensioning and one screw, and then final position with a well-aligned canal for any subsequent procedures. So as a very brief summary of sort of an aggregate of all the things that people have done over the years for various non-traumatic deformities of the proximal femur. The great thing about these techniques is that they're readily transferable from a trauma skill set that you've already seen now on 2 separate Saturdays for addressing mal and non-unions of the proximal femur. So I'm hopeful that somewhere out there in the audience, there's going to be an interest for expanding your trauma skill set into a broader hip preservation set. That I'm going to.
We'll just take a few minutes for questions. There's some really good ones that came in. First one for Roger, if you can go ahead and put your video on and mic. So you had talked about kind of when to consider not operating. When there was a question about when should you not operate with respect to the time duration of the non-union, or is that even a factor for you?
I'm not sure what the question is totally. Is it
Like, is it ever too late, basically, I think is what they're getting at.
Is it ever too late? You know, I think that if you do have very large cavitary defects in the head that sometimes happening with, you know, kind of windshield wipering of the, you know, whatever implant that may be in there, if you have a large defect in it, yeah, like those people, I think maybe they're, you know, those are difficult to do. I don't think it's too late. I mean, I had that one lady come back and I thought for sure her femoral head was going to be dead, you know, and so I've been pretty optimistic overall. And Jeff Mass taught me that. He taught me to be optimistic about, you know, tackling some of these things. And a lot of times for young patients, I think it's worthwhile to make these attempts. Rene Marti has said that in his article too. He said, young people, you know, give it a shot, even in face of avascular necrosis at times. He felt like it's not too late. He sometimes tried to save those people, and I know we have as well. So I'm
that's
pretty sure.
Yeah, that's a great segue into the other question was about potentially osteonecrosis being a contraindication.
Mm-hmm.
So are you getting MRIs on these folks, or are you just going by radiographic changes?
Yeah, I'm not looking for it. I don't get MRIs. I'm not trying to find some reason for me to not do this, honestly. And, you know, so far I haven't been burned on that. If I do see collapse of the femoral head from avascular necrosis, then I'm thinking, you know, I'm probably not going to do the osteotomy on them.
Okay. Keith, and Roger, both of you, since you both showed allograft hawks. So how do you preserve the blood supply to the head if you do a relative neck lengthening or add an allograft?
Yeah, Keith, you want to tackle that?
Yeah, so the both relative and absolute neck lengthenings require an extended retinacular flap. And that is a separate take. So essentially you're mobilizing the ascending branches posteriorly. And so theoretically, it's the same approach you would use for either an acute or a chronic slip. And so that's an approach you have to be comfortable with. And it's relatively straightforward in young patients and much more difficult in older patients because the retinaculum is much thinner.
Okay. Anything that you have to add, Roger? Any other?
I guess the only
tricks?
thing I would add to that was that I don't do retinacular flap 100% of the time. And the case that I showed you, I used that large allograft piece of bone. And that lady, because she was 72, I told her, look, there's a possibility that your head could go onto AVN if this doesn't work. I did not do a retinacular flap on her. And I was fortunate, I think, in that instance. But I knew what my bailout for her was going to be no matter what. So.
Okay. Well, with that, we'll move on to the next section with Mark Riley. I'm going to stop my share.
Okay. So you've just seen some beautiful, beautiful osteotomies from the last two presenters. That's going to stop for the next 10 minutes. You know, for trauma surgeons, you will certainly be faced with dealing with femoral neck nonunions and malunions. I'm asked to speak on Pertrochanteric malunions and nonunions, which does pose some differences for sure to the femoral neck. For one thing, they're quite uncommon. Non-unions of the intertrochanteric femur is estimated to only be about 1% to 2%. And the ones that don't heal are oftentimes neglected or infected as a complication. Malunion, it's interesting, some authors will say malunion is also an uncommon finding. And I think others believe that the malunion rate after intertrochanteric femur fracture is extremely high. In fact, nearly universal. It's so uncommon for an intertrochanteric femur fracture to heal in a perfectly anatomic position. But we can definitely say that symptomatic malunion is quite uncommon. So what's the typical deformity? Well, obviously there's usually some varus, but not always. Typically the femoral shaft is medialized and the leg is shortened. And then there's also the likelihood that there may be some malrotation. That malrotation is usually excessive anaversion, and that's most likely from the patient being positioned on a fracture table, the leg internally rotated to make the AP appearance of the fluoroscopy better. And in fact, what that does is to create an excessive anaversion and fixing the patient with a malrotation. I'm not going to spend a lot of time talking about rotation at all because that's the subject of our next talk from Dr. Miranda. The patients will usually present with a limp. They'll be complaining of gluteal dysfunction and weakness from the high riding greater trochanter, resulting in a Trendelenburg gait. They'll tell you they have a limb length inequality on the malunited or non-united side. And they will typically have pain, particularly if they have a non-union, but they can also get abductor-related fatigue pain from the gluteal dysfunction. They can get trochanteric impingement from the abnormal varus position of the proximal femur, and they may have hardware-related pain over sites of prominent protruded or failed hardware. And of course, long-term, we can't ignore the effect on the knee or the spine, which is that persistent medialization of the femoral shaft will overload the lateral compartment of the knee, leading to symptomatic lateral knee pain and potentially valgus deformity, and the long-term effects of leg length discrepancy can have effects on the lumbar facets and obliquity of the pelvis. So why does it happen? Well, it happens for some reasons we can't help. Intertrochanteric femur fractures typically happen in elderly patients with a lot of comorbidities. Their bone quality is quite poor. We can blame it on the patient and say they didn't protect their weight bearing, but of course we shouldn't be asking them to. But those are things that we can't control. But so much of the reason that we see pertrochanteric malunions and nonunions are modifiable, and that is that the reduction achieved is poor initially. The implant choice may be incorrect. The implant may be inserted incorrectly, or the surgeon may not recognize comminution posterior medially or fracture characteristics that lead to an increased rate of failure. But the thing is that it doesn't just happen in old people, it happens in young patients as well. And so if we're going to be considering an osteotomy for a pertrochanteric problem, our goals really should be to restore the patient's anatomy, to eliminate their limb length discrepancy. Moving their trochanter into a normal anatomic position will help improve their gluteal function and decrease their limp. We hope, we believe that restoring the patient's anatomy will result in relief of pain. Obviously, if there's a non-union, we want that to unite, and we certainly want our osteotomy to unite. And in fact, the osteotomy through the intertrochanteric area can help with union from both a mechanical and a biological sense. From a biological sense, we get fresh cuts that may remove some atrophic or avascular bone, and done well, an osteotomy gives us the opportunity to compress two broad surfaces under strong compression and achieve union, hopefully with minimal complications. I think it's important to tell patients that the restoration of the anatomy it's unlikely to completely eliminate their symptoms, but we have to believe that an incomplete correction or leaving persistent deformity has got to be worse than making their femur as close as possible to the shape that it was before it was injured. So why is this so uncommon? Well, it's so uncommon because it typically happens more to elderly patients, as we said, with poor bone quality or pre-existing hip arthritis or hip arthritis secondary to cutout of an implant or failure of the implant. There's significant bone loss in the soft bone from the previous implants. And so surgeons will oftentimes suggest or select arthroplasty. And I think it's not unreasonable for sure in this patient population. It's a quicker and easier operation with less morbidity than putting the patient through an osteotomy and then having them heal. But we still see these problems in young patients where an arthroplasty is not a great option. And so if we don't know the role of an osteotomy in these situations, then it becomes something that is a lost art and is not thought of. In fact, it's interesting that that Hardy Weber over 30 years ago bemoaned the fact that the art of the intertrochanteric osteotomy was being lost. And if it was being lost then, it's probably even closer to being lost 30 years later, unless surgeons continue to talk about it and teach its advantages. So how is our planning different from that for a femoral neck nonunion or an atraumatic proximal femoral deformity? Well, it's not really that different, except that we have a sagittal plane deformity quite commonly that we really have to address. So the coronal plane deformity, we can utilize the techniques that we've seen so nicely discussed, templating from the contralateral side to determine our angular correction. But it's really important to, in these injuries, to identify the sagittal plane deformity and include that in our plan for correction as well. And of course, we recognize that it's not two deformities, one in the coronal and one in the sagittal plane. It's a single deformity that happens to be non-orthogonal to the two planes that we have x-rays in. So that's the angular deformity, but then we have the axial deformity, both length and rotation. As I said, I'm not going to talk about rotation, but the shortening. So similar to the femoral neck, our techniques for reestablishing length through the osteotomy is either the amount of wedge that we take, so the width of the wedge. If we go all the way across the femur, we don't achieve as much lengthening as if we take a small wedge, where we get much more lengthening, but in exchange for less bone contact. And we also have the possibility, if our osteotomy is oblique, to lengthen and lateralize lengthen the leg by lateralizing the shaft along the obliquity. And of course, the more oblique that osteotomy is to the shaft, the more length we'll get for the same amount of shaft lateralization. But we don't want to overdo the shaft lateralization, or we'll throw the patient's mechanical axis through the medial knee. So the osteotomy, it can be combined with a greater trochanteric osteotomy. The green line there on the plan is not the trochanteric osteotomy. That's an axial line for alignment. But it's infrequently necessary because in the intertrochanteric malunion or nonunion, the relationship between the head and the trochanter is often maintained, or it's acceptable. And so oftentimes we can work with the proximal femur as a single piece. And in fact, sometimes the osteotomy for intertrochanteric femur fractures or malunions is actually easier than planning that for femoral neck fractures. The fixation has to include compression, whether you get it from mismatch compression, offset compression, as Roger told us, or whether you get it from axial compression through an articulated tensioning device. We have limited surfaces of bone. The intertrochanteric osteotomy for this situation, we have the possibility for large surface areas, but still without compression, we're likely to run into problems with our osteotomy healing. We want a fixed angle, absolute stability construct. And we don't typically need to bone graft large defects, but any bone that's left over can be added to the shoulder of the osteotomy to help for healing in these situations. So coronal plane deformity, how can we plan for that? Well, I never knew how to plan for that and how to translate that to the bone, but a technique that I've been using is the wire technique that Keith described. And so you can see that on the left, this isn't an intertrochanteric malunion, but it's just a description. You can see on the left, I've got wires that are set up for my wedge resection. On the right, you can see there are two cranial wires. One is more cranial than the other. That's for a 10-degree correction in the sagittal plane. So I didn't have the lateral view, but if you were to look at those two wires on the lateral plane, they would be at 10 degrees to the orientation of the proximal fragment. And so now if I use those wires for my osteotomy, I can both get my coronal plane correction that I planned for, as well as getting now a sagittal plane correction that'll allow me to correct what is typically a flexion deformity in these injuries. And I don't know how how other surgeons do that, and of course would love to learn. Complications, thankfully, are pretty rare. One is avulsion of the greater trochanter. I think we've probably all seen that. As Keith showed in his case, you can have a fracture or crushing between the blade insertion site and your osteotomy as you compress, particularly in older patients where the bone quality is soft. Non-union of the osteotomy is really, thankfully, quite uncommon. This area of the bone heals quite vigorously, and so that's not something we typically run into when the surgery is done well, but we do see it sometimes, and of course, other surgical complications. So if we look at some cases, these are cases from my first 10 years in practice. And the reason that I selected those is because there were technical errors. And I think that certainly for me, I learned most by critically looking at what I should have done differently, what I should have done better, and performing the osteotomies in a different way. So this was a young woman, a 39-year-old female with this intertrochanteric femur fracture malunion. She's around a year from injury. Her main complaint was hip pain and inability to flex her hip. She also had lateral pain over her implant, which was quite prominent. She was relatively thin. She had a leg length discrepancy of about 2 centimeters and a quite significant gait. She's 39 years old and she's very unhappy with this situation. So we need to quantify and understand our deformity, right? And so got about 13 degrees of flexion on the lateral view and 16 degrees of varus. And so my thought was she's about 3 centimeters short, excuse me. And she's around 10 degrees of excessive aneversion. Not terrible, but something that has to be considered. So in the operative plan, I wanted to perform a closing wedge osteotomy that would correct her angular deformity and also then allow for a correction of the flexion deformity. So the rotation being only 10 degrees, my plan was to ignore it and reassess. And so what happened intraoperatively? Well, I took my planned wedge out and closed it down and was happy with the alignment there. Inserted my implant and just as you would expect, I ended up lining the front of the bone up because I incompletely and inadequately planned the osteotomy, I ended up with a posterior gap. So now I have two surfaces that I can't stably compress because I'm really riding on a very small knife edge of anterior bone and I've got a posterior defect. And rather than shorten the patient more to achieve better surfaces to compress, I thought she was young. I could stabilize the osteotomy. I placed a neutralization screw across it and used my wedge to bone graft the posterior gap. That's her a little bit post-operatively there. And by 6 months, it's gone on to fail. So what did I not do? I didn't have a compressible surface. I did not achieve a stable construct. And so now I've got you can see the plate bending into varus, the screws are failing. And now I have a non-union of my intertrochanteric osteotomy that I caused. So an unusual problem, not something easy to read about. I reach out to my colleagues and my friends, and I think it was Keith Mayo who told me that sometimes the second time around on an osteotomy, you now don't have clean surfaces, you'll have irregular surfaces because of the non-union, and now it will achieve compression. And so I went back, removed the blade, inserted a new, actually the same blade, but same dimensions, but in the same path. And all I did was use the articulated tensioning device and provide axial compression of this. And now the compression would hold. There was no bone graft added. I didn't do anything except compress. And about 3 months later, you can see she's completely filled that in and healed her osteotomy. And then had her hardware taken out at some point in the while later. So what should I have done differently? I should have planned better. I should have understood the coronal plane deformity. I should have ended up with compressible surfaces and not relied on a neutralizing implant with bone graft to heal an osteotomy. So lesson learned. This is a 28-year-old female presented with this x-ray. She is about 9 months after injury. She had an intertrochanteric femur fracture, which was probably through either an aneurysmal or unicameral bone cyst, resulting in such a severe collapse. Her main complaint was pain with abduction, in that she really couldn't stand up straight without her trochanter impinging on her pelvis. She was 4.5 centimeters short, extremely unhappy. So options here. Well, you could distalize her trochanter or perform a relative neck lengthening, but you're leaving her with no offset, with a very medialized femoral shaft. And in a 28-year-old, she's going to run into knee problems down the road. Plus, she's still 4.5 centimeters short. So I didn't think that that was a good option for her. And again, reaching out to my friends and colleagues, they pointed out the similarity to the deformity that you see in Perthes, and had opportunities to do double absolute neck lengthening osteotomies for Perthes disease. And so it seemed like, although this was a traumatic situation, it seemed like this would be something that would be possible. So we obviously want to try and get as much of the length back as possible. We want to improve the offset between the femoral head and the shaft. That's going to require lateralizing her shaft, lengthening her along a long oblique osteotomy, repositioning her trochanter, and replacing the bone graft with allograft. So osteotomy looked something like this, with trying to restore her neck length by lateralizing her through the obliquity. There was also a small closing wedge to increase the valgus at her fracture site, and then to bring her trochanter down and fill the resultant space with bone graft. It looked like that post-operatively, and you can see that very large allograft between the femoral head and the trochanter and the intact shaft. And so you might think that that would not unite. Here she is post-operatively. As I think, if you get advice from people about your cases, you need to show them the post-operative x-rays. And so I had the opportunity to show the x-ray to Jeff Maston, to Keith Mayo, and to other colleagues and friends. And everybody said, why didn't you fix the trochanter down? And yeah, so 5 months later, she's healed her osteotomy, and her trochanter escaped and broke off of the top of the blade. Totally avoidable complication on my part. So once I thought she was healed enough, a few months later, I was able to pull her blade and then bring her trochanter down and try and refix it. And she moved subsequent to this, but about 10 years after her surgery, I got a card from her saying that her hip was functioning well. She had had her hardware removed. She did not use a lift. She thought her leg lengths were very close to equal, and had no hip pain, and was very appreciative and very happy. That's a CT scan that she was able to send me, but you can see that her trochanter, after her hardware came out, still escaped. So in summary, intertrochanteric nonunions and malunions are rarely treated with osteotomy, but this situation will come up where an osteotomy is the best solution for it. And we can't always rely on arthroplasty. The principles and techniques for correction are similar to those for femoral neck osteotomies. And we have to understand and plan for all the components of the deformity. And of course, maximize osteotomy surface area and compression. I just wanted to finish with one thing. It's more for me than for anybody else.
Over the past month, I've had the opportunity to reflect on this topic, on how a surgeon acquires the ability to perform a complex procedure where there's not much information available for review. When planning some of these cases, I had only Professor Schatzker's book with a chapter by Maurice Mueller available to review, and this didn't really include the nuts and bolts of planning this operation. So instead, it's an organization like the AO that creates the opportunity to meet and learn from master surgeons who gave freely of their time and expertise to ensure that I was prepared as possible for the challenge. And along the way, you meet other master surgeons. And as you struggle to improve, you have the opportunity to meet other like-minded surgeons also working to master their craft. And you get the opportunity to learn from their experiences as well. And if you're really fortunate, you develop relationships with those surgeons that last a lifetime, that I could call such esteemed surgeons my friends, not to mention the fact that during the preparation of a lecture on this topic, that I would have available to me on my laptop cases from each of these surgeons to review and to learn from. For that opportunity, I thank the AO, and I thank you all for your time.
I think Mark just said exactly what we all feel as far as the ability to meet mentors and friends that help us become better surgeons and be able to take care of our patients better, for sure. So that's awesome. Thank you, Mark. We'll go ahead, and last speaker will be Mike Miranda.
Good morning. Hope everybody can hear me. Mark, thank you for that. I feel similarly. I'm so pleased and honored to be associated and to call you all my friends and to learn from each other as we go through this journey. It's really a consistently exciting thing to do, and it's really the fabric of my professional life. So I'm going to talk to you all this morning about rotational deformity of the proximal femur, look at the indications for osteotomy and technique. Brett went over the disclosures. At the end of this session, the learner should be able to understand the importance of some objective data in evaluating malrotation, understand the indications for surgical intervention, understand the various techniques available for managing this problem surgically. So we're going to start off with a case. This is a woman. At the time, she was 56 years old. She was 8 years status post a motor vehicle accident, and she had suffered a number of different injuries. The one that's pertinent to our discussion is she had a right intertrochanteric hip fracture. It was initially managed with a trochanteric femoral nail, and the nail went on to be removed due to persistent pain. She went on to relocate, moved locally, and she presented to my office with complaints of a painful gait. Her complaints otherwise were anterior knee pain, thigh pain, weakness, and difficulty with endurance when walking. She noted that she couldn't make it through the grocery store without having to stop and rest. Now, this is her gait. She has a contralateral tibial talar fusion, but you can see here that she has an internal foot progression angle, which is different, right? She has a prolonged stance phase, or it's her right side that we're looking for, and she has some weakness in her pelvic stabilizers. So you can understand why she would have a problem. This is her physical exam with regard to rotation. So she's got some marked asymmetry with regard to her rotation. AB and E deduction is mildly different, but not as impressive as the discrepancy in her rotation. These are her x-rays. When you look, you can see that obviously she's got a deformity of her proximal femur. You look at the lateral in your you're fooled somewhat into thinking that it looks pretty good, when in actuality later on I'll show you that it's markedly displaced. This is a computer scanogram. I don't have a formal scanogram for you, but it can show that in general her overall alignment isn't bad. It's off, seems like it's in a little bit of valgus. And again, it's something to take in and use that data to help you make some decisions. Her CT scan shows some discrepancies, okay? So you can see this is a fairly complex case, right? So when you evaluate these patients, you have to take that information, or at least I would encourage people to do this, create a problem list, look at your indications for intervention, look at the opportunities, the different techniques to put them together and create a plan of treatment that you present to these patients later on. For these folks, I usually evaluate them and on a separate occasion, come up with a plan, a separate occasion, have them come back and discuss that plan. So you need time to sort of chew on this stuff, and that's what I do. So let's go over some of the highlights in the evaluation, and I'm taking it back a couple of levels just because these patients walk into your office and you need to understand that if it's a malrotation problem, there are certain things that you need to pick up on history, physical exam, as well as the imaging. So the current symptoms are really important because you want to make sure that you address them to the patient's satisfaction. You need to understand the injury, the treatment, their physical exam. We'll talk a little bit about that, the x-rays, as well as the CT scan. With regard to history, malrotation patients can have very vague symptoms. This woman, she has anterior knee pain, thigh pain, weakness, poor endurance. I mean, that's a number of different potential etiologies. Could have just been poor rehab, right? She has some quad weakness that gives her some anterior pain. She could have a missed injury. She could have poor endurance because of her cardiac system or another system, or she could have had a patellofemoral injury like so many of our femur fractures do. So there's a lot of different reasons why malrotation can be missed just on the history. So this is a woman, this is a prime example. This is a really wonderful lady. She came into my office. She had seen a couple of other folks, and her chief complaint was fatigue with walking. And even though she has a fairly significant external rotation deformity, it wasn't picked up. And I'm not trying to fault anyone else. I'm just saying that you really have to look for what the patient is complaining about and try and assure that there's no pathology there. So their symptoms are inconsistent. Why? And it's because patients have different thresholds for tolerating malrotation. A lot of this has to do with their pre-injury hip rotation, but also the direction of the deformity affects tolerance. So if you have a minor malrotation from 10 to 14 degrees, only 3 out of 26 patients in one study had complaints. If you have a greater than 15-degree difference, only 8 out of 21. So you can see that they're able to tolerate a fair amount of displacement. Symptoms, again, anterior knee pain, usually seen with stair climbing, running, and sports. And if consistently, if you have a 10-degree, greater than 10-degree external rotation deformity, you have some patellofemoral joint symptoms. So these folks will come in, they'll complain of anterior knee pain. You'll think, oh my goodness, just another patellofemoral problem, send them out on their way, but really they have another issue. On physical exam, you can evaluate these folks a number of different ways. You can evaluate them. The patient could be supine with the hip extended, the knee extended, supine, hip flexed, knee flexed, prone with the hip extended and the knee flexed. Which one of these is better? Well, you can see this is hip extended, knee extended. This is Dr. Bird doing an exam, hip flexed, knee flexed. And this is another patient prone with the hip extended and the knee flexed, okay? Turns out that the prone exam is actually the most sensitive for picking up the degree of discrepancy between the sides. How sensitive is each of those exams to picking up or to the measurement that you might find on CT? It's actually 20 degrees off in one study fairly consistently. So it's one of those things that that's why you need to have to get the data. We're going to talk about that a little bit more. With regard to physical exam and gait, these folks have a characteristic type of gait. When you look at gait, you want to make sure that you look at the foot progression angle, try and have an understanding of where the knee is and trying to get some idea or sense what's going on in the hip. So the priorities for gait, Your body wants to maintain the foot progression angle. Next, it'll have the knee axis perpendicular to the plane of motion. And then lastly, the hip will rotate to accommodate to maintain the other two. So again, just saying this differently, if you've got a deformity, you're going to notice that there's hip changes in the hip rotation first. Next, it'll sacrifice that knee axis, but it'll do everything to keep that foot progression angle within 0 to 6 degrees. So that means if you see somebody and if their foot progression angle is off, they're already at the end of their capacity for tolerating that and for trying to accommodate to that. You'll see with these folks with malrotations, especially external rotation deformities, they'll have a flexion movement acting at the knee. When there's flexion movement, the quadriceps fires during the heel strike and the foot flat. So why does this happen? You'll see some external rotation. The line of force falls behind the knee, resulting in the quadriceps firing. So this is a patient of mine. She was 32 years old when she presented. She was 16 years status post to derotation for excessive vanaversion. She was treated with an IM nail, which had been since removed. She had a significant external rotation deformity on examination. She had bilateral flat feet, some comorbidities, HIV, obesity. And here we go. This is her. This is her exam. Now this is her gait. So she can see that she has a shortened stance phase. She has pelvic tilt and she rotates forward. She flexes at the waist to push forward to get her center of gravity anteriorly. And the result of that is she gets a forced knee hyperextension. So it's very, very confusing exam, but once, if you start to become familiar with the pattern, you can pick this up. So it's worthwhile understanding what's going on with the patient's gait in order to try and evaluate how the deformity is creating dysfunction, and then how you can resolve that dysfunction by correcting the deformity. So radiographic evaluation, CT is the gold standard. How did we get there? Well, we know that the physical exam has really a poor correlation with the actual torsion. Plain radiographs. The Dunn method is one way you can evaluate patients' rotation. This is very, very technique dependent, and so is really for historical purposes only. And you can see here on some of the, just a gentle change in the position will give you a different idea of what the antitorsion is. Ultrasound is another way, but it's very, very tech dependent. And that's why we've become for CTs to become the gold standard. And we use the method of GeneMark, but there's a number of different ways that have been described. This is the one that is most consistently recommended and recognized as the way to go. So there is some intra-observer differences. These can be as much as 15 degrees, and they're shown to be highly dependent not only on the CT slice, but where the particular observer draws that line. And so if you all were with us last week and the week before, last week, Raul had mentioned in bone centers that you can use the hip center tool to help identify not only the hip center, but also the center of the femoral neck. I find that's extremely something that's consistent and dependable. So that's really helpful. The MedCAD programmer that Maurizio had used is also excellent with regard to that. Uses a slightly different technique, but again, consistent. So you want to use digital programs to help you to identify these and determine the degree of deformity. So next, with regard to indications for these patients, you have to really look at the patient's complaints with regard to their malrotation, understand the deformity. You want to create that plan and then review that plan. The indications for surgery for malrotations are rarely absolute. We'll go through what the current recommendations are. But patients are also, their complaints are very, very important. You want to make sure that you understand where their pain's coming from and the degree of dysfunction. Remember that there are some folks who will have some type of abnormalities, and this is dysmorphia, that's a psychological issue. You want to make sure that you recognize this so that you can satisfy the patient and make sure that you have a proper indication for intervention. So it's critical that you understand that chief complaint so you can address not only the patient's concerns, either surgically, or make sure that you modify their expectations so that they end up being satisfied with the interaction. So with regard to malrotation, the question is the deviation inside or outside of a bell-shaped curve? Well, we know that from CT-based studies, 95% of mature healthy population has less than 11 degrees difference femoral anteversion. 99% of the population will be less than 15 degrees. So in general, most folks have taken the position that a difference of 15 degrees or more is considered having a true rotational malalignment. Internal versus external rotation. Are they the same if there's, or it should be malrotation, right? So the foot progression analysis indicates that external malrotation is much more difficult to overcome than internal malrotation. Patients with external rotation and malrotation greater than 20 degrees scored worse on functional outcome scores and had more difficulty climbing stairs than internal rotation. Now on to technique. We've seen a lot about technique this morning, some amazing cases that I wish I could call my own. Were always fun to look at. So this particular table is something that I organized, and it helps me think, because when I create my problem list, I want to be able to go back and look and have this as a reference. And something that I can use to help me decide where I'm going to go and how I'm going to create my correction. So in the proximal femur, it's uncommon to see simple malrotations. They're often combined with other deformities. And the reason why is because the femur is a curved bone. It's not a straight bone. In other words, its mechanical and anatomic axes are different. And so as a result, the deforming forces often cause displacement in other planes, in more than one plane. And so your plan should be to resolve the other deformities and then address malrotation. As a result, you need to have an osteotomy that ends up being transverse. That's the way to simplify it. There are complex single plane osteotomies which can be created and determined mathematically. I find that process burdensome and very, very challenging. Frankly, I just don't think I have the cortex, the cerebral cortex, to accommodate it. And so I break it down to the simple planes and fix it that way. So let's get back to our original case. We've got our 56-year-old woman. She's got this deformity on her x-rays. And this is her CT scan. I think this is probably the most helpful portion. And I enjoy looking at 3D CTs of deformities. It really helps my brain figure things out and get it wrapped around. So that you can see that she's got an intertrochanteric fracture which was displaced and rotated. So you can see she's got some prominent bony landmarks. So intraoperatively, I know that that's going to help me out. So when I created her problem list, and you see that she's got 45 degrees of interrotation. She's got a seaming varus of 16 degrees. She does have some translation of that of the distal fragment laterally, just slight, and she's got a leg length discrepancy. But the leg length discrepancy is from her contralateral tibial talar fusion. So when we start looking at these and trying to correct this, remember we want to create corrections that leave us with a transverse osteotomy so that we can affect the rotation afterwards. So if we do a varus closing wedge osteotomy laterally, that's essentially a valgusization osteotomy. This has the potential to lose some height and actually will help the leg length discrepancy on our contralateral side. And it'll also leave us with a transverse osteotomy. What's next in the line of thinking? What implant am I going to use in order to fix this? Because I'm creating, or I'll end up with a very simple fracture line or osteotomy line, I would like to create compression, and so I'm going to use a blade plate. If there's different circumstances, you may pick out a different implant. In this situation, I chose a blade plate. And this was my plan. And this is the execution. And this is the execution you've seen with previously. We've got distal reference wires. We've got a proximal wire. And I use the metal triangles that are available in the osteotomy set. You set up the blade with the chisel. and set my blade in. Remember I essentially put the chisel in, back that out, set up my osteotomy with wires. Now, unlike Roger, I actually ride the wires with my saw, and I think that's probably a certain comfort level. Roger's a master technician. He's able to freehand it and make them look beautiful. For me, I depend on those wires, and so I'll ride the wire and then drive in the plate before I finish my osteotomies. Okay, get everything all set, and then do my rotation, and then compress it, assuring that I've got a satisfactory derotation. I check alignment, make sure everything looks good, and then it's our final. Let's look at another case. This is a young man, 38 years old, had a history of a femur fracture when he was young, age 12. He was treated closed. He developed avascular necrosis, and he was actually referred by one of my partners. He was referred by my arthroplasty partner for potential osteotomy in order to resolve his malalignment before proceeding with the total hip. So you can see here he's got some flexion, 17 degrees. He's got varus at 13 degrees, and he's malrotated 10 degrees. He's got a relatively minor malrotation, but still, if I'm going to fix it, I'm going to just try and get as much done as possible. So I've got my problem list here. He's got a 2 centimeter leg length discrepancy, AVN of the hip. He needs a total hip. And so all that's going to come into play as we're going through the thought process of how I'm going to execute this. He's got a leg length discrepancy. I know he doesn't want to rock the Herman Munster boot. So I'll try and address it if I can. But the reality is that if the only way to resolve that is to create an opening wedge. Well, opening wedge osteotomies in the lower extremity are inherently unstable. Plus, it's very, very difficult to do rotation because you'll have very, very little bony contact. So unfortunately, I can't do that. I'm going to have to do a closing wedge osteotomy. So I also need to make sure that he gets set up for his total hip, because that's the next step. So I'm going to try and avoid a plate, and I'm going to use a nail to fix this. Also, the nail assures that the ultimate architecture, he's going to be able to get an implant down into across the osteotomy site and fix it with his total hip. And so you can see here again, using my going back and looking at my table, it's very helpful. So we're going to do a closing wedge osteotomy, derotation, and fix it with a nail. And you can see here fairly quickly, we'll go through. So essentially we start the nail, get everything all set there, get your osteotomy all set. I use, for some of these osteotomies, a very convenient way to do it is to take the small X-Fix set, and the one that's for the hand and wrist, use 4 O'Shan's pins from there, put those in, and then set the angle that I want to correct. In this case, derotate internal rotation. So there's 10 degree difference between the proximal segment, distal segment pins, and then derotate and then set up my nail and then end up finishing. And then he goes on to get his arthroplasty by my partner. So the take-home points for this particular talk are that symptoms and malrotations can be vague. It's really helpful to use digital software to measure the differences. This way you can be consistent. And you want to make sure that you understand the patient's concern and individualize your treatment to fit the patient's needs, and do so via a problem list. Thanks for your attention.
And so since we're a little short on time, I was going to mention a few questions. So if everybody could get back on, Roger, Keith, Mike, and Mark. There's a question from the first section that we didn't really address, but could you comment on when you decide to do a trochanteric transfer? But Roger can go first, and then if there's anything else to add, I'll have Keith comment.
Yeah, so troch transfer, because it really increases the complexity of the entire operation, I try to be pretty considerate about when I do one and don't do one. And a lot of that has to do with sort of the symptoms that the patient's presenting with. So the trochanter itself can lead to extra articular impingement, as Mike was just talking about with respect to rotation. So if they have issues with that, that's one consideration that sometimes lead me to think about transferring it or distalizing it a little bit. If their abductors are really quite weak and I'm not able to get the trochanter, you know, in a good enough position, and one of my goals is to really work on eliminating their limp, I'll think about doing the troch transfer as well, or the distalization as well at that time. I also think that sometimes when we do osteotomies, you have to make certain that you recreate some muscle tension on the femur, because the hip can dislocate if things are a little bit loose, especially if you're working around the capsule and opening the capsule up. So those are some of the considerations that I have.
Keith, anything to add or disagree
Yeah,
with or anything like that?
basically, you're starting with a normal neck length, then it would be rare to want to transfer the trochanter. So it's the length of the neck and the position of the trochanter relative to the hip center, which determines whether or not you're going to want to do it. Because it does clearly create an additional layer of complexity. So you have to either you have to cannulate the trochanteric fragment with your blade, or you have to attach the trochanter proximal to the blade. Both of those are challenging. So I think if your symptoms are, you think in part impingement related because of a short neck, then you may have to go the extra step in a younger person of going ahead in a situation, I've only done it rarely, but with a true surgical dislocation and osteoplasty, and then addressing the neck length as you've seen several times today.
And Mark had one where he fixed it with, went back and fixed it with the plate and screws. What is for both, for all four of you actually, what is your kind of typical fixation construct for if you have to advance the trochanter?
Well, if you have a stable osteotomy bed and you have good bone, the screws are adequate. But the insurance policy is a tension band wire, which usually goes underneath the shoulder of the plate. And that is a soft tissue tension band, typically, unless you have a very large trochanteric fragment, you don't try to go through bone, and the trochanter basically is going through the medius tendon. It's a tension band.
Anybody have any other thoughts?
Yeah, the other thing I want to say is just point out is that when I do the trochanteric osteotomy, you run your saw to take the trochanter off, and then you create a small window in there for your blade to go through, to pass through, and then you pass it through the proximal segment. Usually that distal end of the trochanter is thinning out pretty significantly, you know, so that, you know, it looks okay at the time of surgery. You might be tempted to say, oh, that'll hold it, but I wouldn't go with that, honestly. And most of the time, put some screws in addition, and then sometimes I'll actually put that tension band wire, as you saw in that case that I had. I don't see any real downside to doing that.
That's been my experience, that when I skewer the trochanter, cannulate the trochanter with the blade, if I don't protect it, particularly for a significant valgus, that the trochanter seems like it has a very high incidence of fracturing around the blade.
And then maybe since several people mentioned allograft, what is your go-to allograft to augment your osteotomy?
Again, for me anyway, it depends on the size, but usually a femoral head allograft, I think, is easiest to. You have got plenty to manufacture, and you know, wedges or squares or blocks in exactly the size that you need, and can make them trim to fit. So for me, it's usually a femoral head, frozen.
Keith, you were the only one who didn't shake his head yes, so I'll ask you what your go-to is.
Ideally, if you had enough selection, I'd take a humeral head because it's more porous, and because what I end up doing is if I use a femoral head allograft, and I end up drilling about 30 holes in the cancellous portion of it to make it look like a humeral head. So I'd rather just start with a humeral head, but we don't always have them. So you use what you got.
So that's a great point.
The one case that I showed, because I had such a large allograft, what I did was just order a proximal femur and took the segment of that proximal femur and cut that out exactly to replace the one that was going to be missing in the one that I was doing, the osteotomy I was doing. So that worked out really quite well.
And that was a frozen?
That was a frozen.
Okay. And then I have another question about orthogonal plating for maybe some of the intertrocks, intertroch osteotomies for intertroch fractures, or if you're doing like the time that I can think of it is an atypical femur fracture non-union is when I would consider orthogonal plating. But when do you guys consider to use orthogonal plating?
I would say I really don't, because most of the time I don't have the access, the soft tissue access to put a true orthogonal plate. Sometimes there'll be the opportunity to put a plate just adjacent to your fixation plate, but really, you know, a well compressed blade, I don't know how much more an additional plate would add to that.
The only time I've ever done it is with in correcting the malunion through the original fracture. It comes out oblique, and so using an anterior plate as an anti-glide to trap and reduce the correct the deformity that way, and then going and putting a neutralization plate laterally.
And I've used like mini fragment plates, not like another 4 or 5 plate. It's usually something smaller, mini frag or small frag, because of the access issue, like Mark said.
Exactly.
And then the last question before we wrap up. So when do you guys ever consider for an acute high angle femoral neck fracture to do an acute intertrochanteric osteotomy?
I do not. Personally, I don't.
I did it twice early in my career. I mean, the best, I mean, it's not been reproduced, but the best series of Powell 3 outcomes was a Dutch report with primary abduction osteotomy and using a blade to fix the neck as well as the osteotomy. Now that's multiple degrees of difficulty greater, because the last thing you want to do is, after you've carefully done an open, I'm assuming you've done an open reduction. In fact, they did not, but I would normally do an open reduction. So I've got a nicely reduced femoral neck, and now I'm going to pound on it with a seating chisel and then pound on it, putting a blade plate in. So I did it twice, and I never did it again. So I think you use your best technique for Powell's 3s, and we know what those options are as far as screw positions and augmenting plates, but I probably wouldn't recommend that.
I think a Powell's 3, particularly in a patient with a native coxa it's virtually guaranteed to fail in that position, even with an anatomic reduction. So that's when I've thought about valgusizing the proximal femur.
Okay. Well, I think with that, we'll go ahead and wrap up. And so the summary for this module is to list the indications for proximal femoral deformity correction and non-union management, and utilize proximal femoral deformity correction techniques to restore extra-articular alignment and to address the non-unions like we talked about. To access the recording, you'll get a link for the participants that registered. You'll get a Zoom link within 24 hours to the recording, and then there'll be some editing done. And on the YouTube AO Trauma North America channel, there's the osteotomy course playlist, and you have to actually go to the AO Trauma North America YouTube channel, not the AO North America, but you can get there through the AO North America. And we'll show that again on Thursday, just to make sure that people have the opportunity to get there. This is another way to register. If you go to the AONA page, there on the splash page, there's the Osteotomy Weekly, and you'll see an area that says Learn More where the arrow's pointing, and that'll take you to this screen where the events that have already happened, you will get a link to the YouTube video. And Dr. Sirkin spent a ton of time, as well as Ron with the AO, getting these videos ready after the events. And they're actually going to be broken up into segments. So once you get to the, if you get to the AO Trauma North America channel, you can actually look at them in segments rather than this link goes directly to the entire recording. And then the areas that don't have the link will go, or they both have links, but one of them will go to registration if the event is still upcoming. So Thursday we have the Meet the Experts, and that's where we're going to go through the cases that we had ready for the expert panel. So definitely tune in for that. Bring your questions. It starts at 8 p.m. Eastern, and we actually have a really interesting case from one of our friends, Brad Yu, that he's going to get some advice on from, as you saw with Mark's talk, just the ability to meet people that will help you be a better surgeon and help you learn things that are really hard. And these are super hard surgeries, but like others have mentioned, some of the most gratifying cases that you can to do and to help patients. So next Saturday is our first discussion group. So this will be, you know, like I said, be patient with the Zoom debacles. Where we had an issue with the link to this week for participants to get, but we'll get that figured out. And then we're going to break you up into breakout rooms, and we'll go through the cases that we have over proximal femur. So with that, we thank you for joining us. There'll be a few short questions that will come up, just to get some feedback for us. If you want to go ahead and put those up. And you just should be able to answer by clicking on the circle. And I think the only one that works is the strongly agree one. So we'd appreciate that one. Except for the bias, there's no bias. So
while you're doing those questions, if you do have trouble and you don't get a link for some reason, you can always go to the registration page that that Brett just showed you, and there'll be a way that you can just click on the link. It'll say join webinar in progress if you are missing the link. But as Brett said, we hope to fix that.